Good evening, one and all. Thank you for joining us. On behalf of Lerma Healthcare, I welcome you all for this informative webinar on KDIGO 2024 guideline, where we hear it straight from our experts. It is my great pleasure to introduce Dr. Vivek Jha, our esteemed moderator for today's webinar. Professor Vivek Jha is the Executive Director of George Institute of Global Health India and chair of the Global Kidney Health at Imperial College London and past president of International Society of Nephrology. He is an established clinician and scientist and has led many clinical trials, policy relevant community research, and basic science research in the field of kidney disease and transplantation. With over 2 decades of experience, Dr. Jha has significantly contributed to advancing our understanding of CKD through his groundbreaking research, which has been widely published in leading medical journals. So, Dr. Jha's exceptional ability to bridge clinical practice with research makes him an invaluable asset for our discussion today. So, we are privileged to have him guide us through this important webinar. So, I welcome you, Dr. Vivek Jha, on behalf of all participants and Lerma team. Over to you, sir.
Great. Thank you very much, Dr. Shah. And let me start by expressing our gratitude to Lerma for putting together this webinar, which has attracted a very large number of audience, which continues to grow. So it's fantastic. And it's not at all a surprise because we have two real experts with us who will talk on two different topics. And I'm pretty sure that you are eager to hear them and not me. I am also eager to hear them here. So the topics that we have today in front of us are the implications of the new KDIGO 2024 guidelines for the evaluation and management of chronic kidney disease. And the second one is going to be delaying progression of kidney disease with very low protein diet and supplemented keto analog diet and other possible treatment modalities. We have, as I said, two real expert speakers, and their accomplishments are perhaps well known to all of you, but still it's appropriate for me to introduce them. We will first of all start with Professor Edgar Lerma, who is the clinical professor of medicine with the section of nephrology at the University of Illinois at Chicago, and he's an educator par excellence. Dr. Lerma earned his Doctor of Medicine and did his initial medical training in the Philippines, and then he came to Northwestern Memorial Hospital, the Feinberg School of Medicine at Northwestern University in Chicago, and obtained a diploma in the subspecialty of nephrology with the American Board of Internal Medicine. He has since then gone on to achieve multiple accomplishments and earned many laurels. He is the education coordinator of nephrology and with his university medical center has authored more than 100 peer-reviewed publications in multiple journals. His clinical work and expertise has been recognized by multiple societies and colleges by awarding him fellowships and recognition awards, etc. His research interests include chronic kidney disease, hypertension, bone and mineral disorders, and dyslipidemias in CKD. But I think it's appropriate to say that he is quite unparalleled in spreading education. In case you haven't done so already, I encourage you to go to Twitter and follow him, especially the hashtag NephPearls. That he tags his tweets with, which are a source of great education. So if you want to find out quickly about any topic, just use that hashtag, and you will perhaps get a wealth of information. So over to you, Dr. Lerma. As I said, people don't want to hear from me. They want to really listen to you. So you will tell us all about the most recent KDIGO CKD guidelines and its implications.
Thank you for that wonderful introduction, Dr. Jha. Let me just see if I can share my screen. Second. You can see my slides, right?
Yes.
Perfect.
Yes.
So Today, I'm going to talk about the key takeaways from the KDIGO 2024 Clinical Practice Guideline for the Evaluation and Management of CKD. As some of you would remember, the last time that these guidelines were published was around 12 years ago. I think in 2012, they published the guideline, and then there has been a lot of updates since that time. For disclosure, I'd like to acknowledge the NEPJC group. A lot of the graphics that I'll be using in this presentation are created by our NEPJC Nephrology Social Media Collective interns. And here are the interns for the present year. And I wanted to acknowledge these individuals in particular because they are the ones who did create a lot of these visuals that I'll be sharing. So let's start off with the top 10 takeaways on the evaluation of people with or at risk of CKD. So here, I'm going to talk about first the evaluation. The second part of this lecture will be management. And then, of course, I'm going to hand it off to Dr. Piccoli afterwards so she can talk about the specifics of slowing CKD progression in terms of diet. So the top 10 takeaways for nephrologists for evaluation, we start off with the CKD definition, right? So when we say CKD, we're referring to abnormalities of kidney structure or function for at least 3 months. So one of the things that is important that's emphasized in the KDIGO guideline this time is that, again, you look at your stages of CKD, right? Stage 1 through 5, and this is based on your EGFR. And it is important that there are many markers of kidney damage. So the main things that we use as markers are the GFR, or glomerular filtration rate, and the albumin creatinine ratio, or ACR. Now, it is important that as we define CKD in a patient, the history and physical provides us a lot of information. And this actually also helps in determining the cause of CKD. So we know that the most common causes of CKD are, number 1 is diabetes, and number 2 is hypertension or high blood pressure. We know that after that, we have glomerular diseases, and of course, polycystic kidney disease is the 4th leading cause of end-stage kidney disease. Now, on the right side, you could see on the y-axis are the stages of CKD from stage 1 through 5. And on the x-axis, you have the classification of albuminuria. And later on, you'll see that this heat map is very useful, not only in the diagnosis, but also in risk stratification. So one of the things that is important in the definition of CKD is that CKD is classified according to the cause, the GFR, and the ACR to establish the severity. And this helps us, physicians and healthcare providers, guide the type and the timing of interventions. Now, here in this list, you will see some of the tests that are used for evaluation of cause. For instance, in a patient who presents with CKD, we do imaging studies, and this will be helpful, particularly in delineating whether the patient has chronic kidney disease or acute kidney disease. A kidney biopsy is sometimes indicated in a patient wherein acute kidney injury is unexplained, or if there is persistent hematuria or even nephrotic range proteinuria. Of course, the laboratory tests, this consists of your usual acid, base, and electrolytes. Where indicated, sometimes you might need to order serological studies like anti-PLA2R, ANCAS, anti-GBM, and of course, electrophoresis. Genetic testing is something that is emphasized in the new KDIGO guidelines, but I know in our audience today, genetic testing may not necessarily be available. So I'm not going to focus on this. And here, an important practice pearl is that it is important to use diagnostic tests based on whatever is available as a resource. And of course, the pretest probability informs us in addition to the clinical presentation. The next important takeaway is that it is important to distinguish between acute kidney disease and chronic kidney disease. As we said, chronicity can be established by looking at past GFRs, albuminuria, imaging studies, as I mentioned, pathological findings like presence of fibrosis, and of course, medical history and repeat measurements beyond 3 months, as depicted here on this slide. Now, whenever we see patients with AKI as they present in the hospital and they get discharged, we know that they, at the time of discharge, if the AKI is not treated, it leads to CKD by the time it is over 3 months. Remember, that's the definition of CKD that we alluded to earlier. Now, it turns out that this period in between AKI and CKD is very crucial. So this is what we call acute kidney disease. It is important in particular to recognize these individuals because this is where you can influence the trajectory, whether the patient will undergo recovery, full recovery, whether the patient will have partial recovery, or if the patient progresses to CKD. And sometimes patients with AKI can also progress to death. So it is important to recognize this. And the next takeaway is that we have to recognize that CKD care across the lifespan. It is important to use a personalized approach to diagnosis, risk assessment, and management, which considers the patient's age, sex, and gender. We know that a patient who presents in the younger years and a patient who presents in their older years will have different risk factors, right? So at the very extremes of age, we know that the modalities that we use for diagnostic and treatment strategies will vary. It's also important to recognize what are the goals of treatment. Obviously, for a person who's younger, you're thinking of longevity. For a patient who's older, you may be focusing also on comfort care. Not that we're going to negate comfort in a patient who's young, but I think it's important to recognize that. Now, there's always the issue of, is the EGFR valid in older adults? We know, and this is something that I emphasize to my patients, as we get older, our kidneys do go down in function. In fact, these studies show that from age 40 onwards, your GFR can decrease by 0.5 to 1 ml per minute per year in the absence of other comorbid illnesses. If the patient has uncontrolled diabetes or uncontrolled hypertension or both, that decline actually becomes faster. Now, what the research has shown is that the threshold of GFR of 60, even in older adults, even in the absence of albuminuria, consistently elevated, is associated with increasing relative risk of adverse outcomes. So this use of GFR above 60 as a threshold is still valid even in older adults. This slide just shows you, again, as I mentioned, as we get older, kidneys go down in function. It's part of normal aging. So when I talk to my patients, I usually tell them, our goal is to slow down the progression. And I emphasize that we are trying to slow and not stop. And the reason for this is because I want the patients and their families to appreciate that we can only slow down the progression. Because age is always going to add to that equation. So 10 years later, when the GFR does go down, they're not asking me like, oh, what happened? I've been following everything you told me and it still went down. So from the get-go, I usually try to emphasize to them that it does go down with age. And again, this is a paper that was published in JASN, which shows that even healthy aging is not associated with preserved GFR in old age. So the fifth takeaway is the use of is the accuracy of the GFR assessment. So estimating GFR from a combination of creatinine and cystatin C improves accuracy and it strengthens the risk relationships. It is important to recognize that cystatin C, whenever available, is useful in this diagnostic process. However, I do recognize that I think in some areas this test may not be available and so may not be widely used. But in those settings, we can still use the GFR without cystatin C. I guess the KDIGO guidelines is emphasizing that if ever it's available, use it. If it's not available, then you use whatever is available in your neck of the woods. So in this table, shows you the initial and supportive tests for the evaluation of GFR. And of course, on the top, you see estimated GFR. We usually base this on whatever is the serum creatinine in the lab test. This is the most useful method that we use to assess GFR. And in most instances, it's the initial test for evaluation of GFR anyway. Other tests, which are listed here, are what we call measured GFR. So this is like using more expensive tests, more cumbersome tests, and they all have their limitations. And even the estimated GFR, we recognize has some limitations. And here shows you the comparison between the estimated GFR and the measured GFR. So in practicality, using an estimated GFR by serum creatinine is probably what we use most of the time. Now, when we talk about accuracy and reliability, we have to understand that there are some limitations of interpreting the GFR and the albumin whenever we determine in the test. So here, I'm just showing you some of the factors causing biological variation in the urine albumin and urine protein. And I'm not going to belabor this, but you could see if a patient has hematuria or is having a menstruation, if the patient is an exercise buff, if there's an ongoing infection. Again, these are things that can falsely elevate or decrease your albumin creatinine ratio or your protein creatinine ratio. Of course, we recognize that the creatinine, the urinary creatinine, can also vary by biological sex, the patient's weight, and changes in creatinine excretion. For instance, you might see a patient who's elderly and frail, and their creatinine might be falsely low. As compared to somebody who is more well-built and is younger. So we have to recognize those. There are also the recognition that some of the lab tests that are used to determine creatinine can be affected by certain medication and certain substances in the blood as listed here. So it's important to recognize this. So I remember in medical school, we always teach that there are things that elevate your serum creatinine without necessarily affecting renal function. So these are important to remember this and recognize the things that can influence the serum creatinine reading before you actually calculate the GFR. Next, use of a validated GFR estimating equation is important. And again, what we're saying here is that there are some, for checking the GFR, going back to my medical school, and I'm dating myself, we used the Cockcroft-Gault equation. That's the only thing we use. And then during my residency, we started using residency and fellowship, you recognize the MDRD equation by Dr. Andy Levy and his group. And then finally, now we have the CKD EPI equation, which is a significantly improved version of the MDRD equation. Now, this CKD EPI equation has been validated in several populations as shown in this slide. And you could see there are different individuals who are actually, who have actually tested for this equation. So I think it's important to recognize that this is the equation that we now use to estimate GFR. In 2021, there's the recognition that race actually influences the calculation of the GFR using this formula. And so there was the recognition that we should not use race as a variable. And of course, there are also societal implications of this understanding. The takeaway number 8 is the issue of use of point of care tests for, say, blood and the saliva and urine albumin measurement. If these are available and if they are quality assured, these may be accurate enough to facilitate the clinical pathway where access to a lab is limited. And again, we recognize that there are some settings that may be resource limited. And I think it is important to understand that in resource limited areas, maybe you might have available point of care tests, which may facilitate determining these values more practically. Use of validated risk assessment tools. So again, I'm showing you the heat map, right? So the heat map is a very useful thing for risk assessment. We know that those who fall in the red category, these are patients who are at very high risk for progression. On the pink, they are high risk for progression, so on and so forth. So when a patient falls into one of these boxes, then you are going to render what is the appropriate test. So for risk assessment, some of the studies that have come up since the 2012 guidelines show that, you have to assess, when you assess urine albumin creatinine ratio or protein creatinine ratio and GFR, you have to check this more frequently in those patients who are at higher risk. For instance, those patients who are in the red and in the pink in the map before, right? Now, the next is that if there's a fall in GFR during the subsequent testing, or greater than 20% or even greater than 30%, this signals the need for urgent evaluation. Of course, if you see a doubling of serum creatinine, this requires urgent evaluation. Another thing that is part of risk assessment is looking at the kidney failure risk. And, I'm not going to belabor this slide, but recognize that there are several validated risk equations for predicting kidney failure in patients with stage 3 to stage 5. I'm just going to show you and highlight this example of the kidney failure risk equation, which is championed by Dr. Tangri. And this is very useful. You are able to use the patient's age, gender, their GFR, and then urine albumin, and then you are able to estimate the risk of progression. Going back to the proteinuria and albuminuria that I mentioned earlier, we also recognize that, and again, these are several studies, as you can see here depicted, that a doubling of the ACR on a follow-up test that exceeds laboratory variability certainly warrants evaluation. So maybe we need to revisit with that patient. Maybe we need to review the medications, or what else can we do? Now, for timing, assessment, and reevaluation, so again, in the past, we have been using the GFR, right? So for instance, for my practice, I encourage primary care providers that when the GFR is between 30 and 60, it is important to coordinate with the nephrologist as far as following up these patients. If the GFR is less than 30, usually the nephrologist takes center stage. If the GFR is less than 20, that is our signal that they can be evaluated for transplant purposes. Now, using the kidney failure risk equation that I mentioned earlier, you could see we can now transition from an eGFR base to a risk-based approach to CKD. So if you calculate your kidney failure risk equation and they're greater than 3 to 5%, and you can see here where it will fall. So I think this is very important. This is part of your risk assessment and equation. So now summarizing evaluation, we talked about the method for CKD staging. We talked about evaluation, and also we talked about use of point of care testing, validated GFR estimation equation. And again, as I said, I recognize that cystatin C may not necessarily be available. So one of the things that's important with the guidelines is that they are something called practice points, wherein the evidence may not be as robust as compared to level 1 and level 2 recommendations. But these are very practical for our practice, right? For CKD detection, staging, we have to evaluate for chronicity, estimating GFR, costs, and of course, GFR and albuminuria are important tests. Now, the second part of my lecture is the 10 takeaways for the management of people with or at risk for CKD. So the first important thing here is we have to emphasize lifestyle, healthy diet, and physical activity. We recommend to stop tobacco products if they're smoking. I always tell my patients, now we have discovered another thing that tobacco does, aside from cancer and pulmonary problems. It causes CKD progression. So important, healthy diet, physical activity, stop use of tobacco products, and also weight management. So I'm not going to belabor this slide, but patients with CKD are recommended to also undertake some activity, moderate intensity physical activity for cumulative duration, at least 150 minutes per week. And this is given a strong 1D recommendation. And of course, again, physical activity, avoid being sedentary, so on and so forth. Adopting a healthy and diverse diet. So there's emphasis on the use of plant-based foods over animal-based foods and avoidance of ultra-processed foods. I'm just going to touch on this briefly because I know Dr. Piccoli is going to talk about this as well. So in the KDIGO guidelines, we recognize the difference between animal proteins and plant proteins. And also, we recognize the badness of ultra-processed foods, right? This slide shows you the different potassium contents and the potassium absorption rates, rather, of different foods, whether they're plant-based foods, animal-based foods, and processed foods. And you could see on the rightmost figure, you could see ultra-processed foods really have a high constituent of potassium. The evidence supporting the use of plant-based foods in slowing CKD is robust. So you could see several studies here, and you could see look at the outcomes: decline in GFR, stabilization of GFR, mortality. So all of these are good. Plants are good, and I know in the some areas, plant-based diet is more popular as compared to other, say, animal-based diets, and this certainly lends itself to this recommendation. Important to individualize blood pressure control, right? So the CKD guidelines for blood pressure recommend a target systolic blood pressure of less than 120. But in patients who have frailty, who have high risk of falls and very limited life expectancy or symptomatic postural hypotension, you might have to temper that, trying to reach the systolic of less than 120. And of course, in any patient, I think it's important to individualize treatment, right? So here you see the pros of aggressive blood pressure lowering. You decrease mortality, you decrease cardiovascular events, but there's also some cons, and you have to take each person individually. Of course, that recommendation of systolic blood pressure less than 120 is primarily based on your SPRINT guidelines, right? And this is the main trial, 9,000 patients, that really showed that in patients in the population, there is rationale or there's evidence to support less than 120 because there's good outcomes that come out. Which blood pressure medication are you going to use? Obviously, for non-diabetics or non-diabetics, the use of ACE inhibitors or angiotensin receptor blockers is fully supported by evidence. We know that in all CKD, with moderate and severe albuminuria, with or without diabetes, and all patients with CKD and heart failure, there is a role for using this combination medications, RAS inhibitors and SGLT2 inhibitors. So we have several studies now published. You have the DAPA CKD, you have the Credence study, EMPA kidney, even the heart failure trials all support the use of SGLT2 inhibitor in most patients with albuminuria. The recommendation also is important to note that once you start the SGLT2 inhibitor and even an ACE inhibitor, there's an expected decline in GFR that is accepted. This is because of hemodynamics, right? So even if the GFR does fall below 20, as long as the patient is tolerating it, as long as the patient is not yet on dialysis, then you can continue the SGLT2 inhibitor. Of course, and I'm going to talk about this later on, the sick day rules. We have to withhold these medications during prolonged fasting, surgery, or critical medical illness. So sick medication rules, one of the things, so I grew up in the Philippines, and one of the things that I grew up is the notion that whatever the doctor says is golden. And so patients sometimes have this thinking that the doctor told me to take this medication, so no matter what, even if I'm getting sick, even if I'm having nausea, vomiting, I'm still going to take my ACE inhibitor and my SGLT2 inhibitor. I think we have to revisit that, right? I think it's important to re-educate the patient that when you get sick, you may need to hold off these medications. I think this is very important. However, on the right side of this figure, you can see there are some patients in whom you appropriately stop the medications. You appropriately stop the SGLT2 and the RAS inhibitor. However, some physicians fail to restart them. Either they forgot it or they got lost in the follow-up. And this is important because this has certain implications, as I will show later. Now, I mentioned about the hemodynamic dip in GFR when you start a patient on an SGLT2 inhibitor. I think this is important. You know, when you talk to the patients and you explain to them, it's very important to emphasize that this will happen. But look at this. The effect is that it's going to plateau, right? The GFR is going to plateau, and you will see that you will give, and again, this is a conceptual scheme, but you may give an additional 15 years of freedom from dialysis. So initial dips in GFR are expected for these medications. A greater than 30% reduction, however, may require evaluation. So we have to think, is the patient having a renal artery stenosis? Is the patient having nausea, vomiting, diarrhea, or some intercurrent illness? So these are things that you have to consider. For cardiovascular disease, important to estimate the 10-year cardiovascular risk using a validated risk tool, which incorporates cardiovascular disease and chronic kidney disease. Remember, you know, I'm not going to talk much about contrast-associated AKI, but this is a condition that we can easily treat. We usually give fluids where patients require fluids, but it is very rare nowadays to have a contraindication to using contrast in these patients. It is important that when you follow patients with CKD, that you always review their medications. It is important to look, are they taking any over-the-counter medicines, dietary or herbal remedies, which can have harmful consequences. So here, this is just a list of the different medications with documented nephrotoxicity. These are common medications we use in our daily setup, right? Analgesics, antimicrobials, gastrointestinal medications, PPI, I'm going to say something about that. This is a post-hoc analysis of the COMPASS trial, which actually showed that there may be a link in the use of proton pump inhibitors and CKD progression. So the moral of the story is that, the thing with the PPI, this is now a common cause of drug-induced interstitial nephritis, right? So one of the things that's important is that we recognize patients have dyspepsia. Here's a PPI. Patient has abdominal pain. Here's a PPI. The patient feels queasy. Here's a PPI. So they have been prescribed very loosely. It is important in our population that we see the CKD patients that we recognize, is this necessary? So take the time, sit down with the patient. Is the patient need PPI really? If not, you can de-prescribe it. However, not all can be de-prescribed. For instance, if the patient has severe GERD, if the patient has peptic ulcer disease, maybe you need to keep them on the PPI. So again, I just talked to you about the different recommendations as far as medication management in CKD. I mentioned about discontinuation, right, of the medications. It is important that when you hold off the RAS inhibitors or SGLT2 inhibitors, you have it in your mind that you are eventually going to restart it. And I want to just show you a couple of studies here. And you could see that in patients who actually stop taking RAS inhibitors, their mortality and MACE events actually increased. And you can see the difference on the right side, right? And here's another more recently published paper, which showed that restarting RAS inhibitors after discontinuation was actually associated with a lower risk of kidney outcomes and mortality. Of course, the incidence of hyperkalemia is not unexpectedly higher. Symptom control. It's important to recognize that the patients can have symptoms, especially with advanced CKD. We know fatigue is the most prevalent and poor mobility is the second most prevalent. And of course, sexual dysfunction and poor sleep have a high severity score. So these are things, we have to effectively communicate with the patients, and, they can tell us what their symptoms are, and we can make a shared decision making in how to manage some of these symptoms as listed here, whether it's pain, insomnia. Some patients can have restless legs, depression, pruritus, or even anorexia. And last, advanced care planning. Again, these are things that we discuss with the patient and caregivers. I know in your setting, this may not necessarily be true. So in the US, what it is the primary care providers see patients separately from nephrologists. I think in your setting, the nephrologists tend to be the primary care physician as well, right? So I think I recognize that. And again, the varied geographical differences in how we do advanced care for our patient certainly varies. Again, I'd like to acknowledge these individuals for the nice visual graphics that you've seen. And with that, I want to say thank you to everybody for your attention.
Thank you very much, Dr. Lerma, for that wonderful and exhaustive exposition of the new clinical practice guidelines, which are very different from the one that we had seen before, right? In the sense of the kind of approach and the practical implementations that they cover. I suppose one bit that didn't get covered in great detail is the importance of identifying the cause of chronic kidney disease. Often we think of chronic kidney disease simply in the G and A kind of framework, the heat map, but identifying the cause is important because that might really change the treatment drastically. For example, if you identify glomerular disease or some other disease. I think your emphasis on personalized treatment and the tools that are now available to allow the treatment to be personalized is really important, and we should really make sure that everyone has the opportunity to use them. For example, the risk-based approach. I think that's really important. And there are a number of tools that are available now to allow us to ascertain risk, which is at individual level. Just as you talked about the EGFR, especially in the elderly, it's also useful to perhaps point out the EGFR in the young. Even though by typical definition of CKD, if someone with an EGFR of, let's say, 85 may not be considered to have, stage 3 CKD, but the EGFR of 85 might indicate already a downward trajectory in someone who is just 25 years old. So it's really important to recognize that if we find something like that, then to be on the lookout and look for other possible causes, especially follow the trajectory of the EGFR or other types of kidney function. We always spend a disproportionate amount of time trying to discuss the best way of measuring kidney function. But I think, as you say, risk-based approach, it's really important for us to follow the trajectory. No matter which method you use, make sure that you use the same method and follow the trajectory. Individual values are important, but trends are much more important. If the EGFR, as you described, falls at a certain rate which is expected, that means something different compared to the rate of change of EGFR at a somewhat different range. So I think there are a number of important takeaways from what you described. You described the 20 takeaways, the diagnosis and the management. But I think we can continue to expand on those takeaways. It's important to also recognize the issue of resource, and for us to recognize the minimum resources that should be available to allow us to ensure appropriate diagnosis and management of all patients with chronic kidney disease, no matter where they live, which part of the world, whatever be the resource settings. So thank you for that. And we will come back to the question and answer session towards the end. But now it is my pleasure to pass on to Professor Giorgina Barbara Piccoli, who currently holds the position of university researcher and is the head of nephrology in the Lerma Hospital in France. She graduated from medical school and did postgraduate training at the University of Torino in Italy. And she set up a nephrology unit in the San Luigi Hospital and was a teacher of nephrology course. I think I see a hand raised. Sanjay, do you have any specific point to make?
None from my side. Please go ahead.
But you have your hand raised, so I wasn't sure as to what exactly did it mean. Okay, so sorry, Barbara, Georgina. So as I said, she is the head of the nephrology in the Lerma Hospital in France and associate professor of nephrology at Angers University. She really has a diverse range of clinical interests, which are fascinating. And her clinical interests are obviously CKD, but with particular interest to diabetic and elderly patients, low protein diet, which is great because she's going to cover that an aspect of that in her talk today. But she also has an interest in home hemodialysis, self-care dialysis, and analysis of costs and quality of life, pregnancy and chronic kidney disease. Her research activity also encompasses topics of contemporary significance, from clinical studies on different issues of chronic kidney disease, mainly diet and pregnancy, quality of life, and ethical aspects of nephrology, including what is really something that we should all be worrying about, which is sustainable nephrology and how to make kidney care more environment friendly or green. She is the editor-in-chief of the Journal of Nephrology and has authored a large number of articles in Medline and in index journals and in many other publications, textbooks as well. She is going to tell us all about delaying progression of chronic kidney disease with very low protein diet and other types of supplements and treatment modalities. Dr. Edgar Lerma touched upon the plant-based diets and their value. But we are very eager to hear from you, Professor Piccoli, about these other ways of modifying the diet and making sure that diet can also act like medicine for patients with chronic kidney disease.
So thank you, so kind. And so everybody will be, will be my talk because I'm not so bright as you described me. But I will try to do my best. So let me first of all try to find my slides.
Yeah, even as you're doing it, I will encourage participants to put in their questions in the Q&A box or in the chat box, so that we have questions for our expert speakers here, because we are going to have a combined question and answer session at the end. But now we have the slides of Professor Piccoli up and ready. Over to you.
So, thank you so much for this invitation. Actually, I got a title that was fascinating, but it was at the same time a bit too large and a bit too small. Delaying progression of CKD with very low protein supplemented diets, okay, very small, and other treatment modalities very wide. So I would try to put the two things together, focusing on intake and on implementation of protein-restricted diets in the context of CKD. These are my conflict of interest regarding diets. We have heard, of course, how big a problem CKD is, and about the fact that it is a problem that it's going to increase and not to decrease in the future. And we already heard about the fact that elderly patients are a really important issue, because as you see, this is a picture from Japan, but Europe is not so different. The number of patients in these countries older than 90 years at the start of dialysis is now higher, and this is also good news, than the number of patients aged less than 40. So the population is changing, and nutrition is central to these, considering also that CKD prevalence increases with age, up to 30% over 70 and even 40% over 80, at least in high-income countries. And CKD is associated with malnutrition. Malnutrition and sarcopenia increase with age, and the increase is sharper when comorbidity is present. And there is another issue that is very important. Dr. Lerma spoke a little bit about it. We are not seeing all the patients. We are seeing a proportion of the patients, and we do not know how many. And the older guidelines tend to tell us to take care of these patients when their eGFR falls below 30 or below 45. So probably a little bit too late to be really effective in changing the lifestyle. But it's very difficult, even in highly resourced countries like France, to answer the need of such a large population. 10, 15%, even in some settings of the overall population, is affected by CKD. On a background of about 2,000 patients that we follow up in our area that follows about 800,000 inhabitants, we calculated that would be half of stage 3 patients. With different projections, we will have either to double up the population of patients that we see or to multiply it by 3. So it's too much. But it's important to acknowledge this, because the different selection of the patients impacts also on the different of the trials. So CKD incidence and prevalence is increasing, especially in elderly and fragile patients. Malnutrition is frequently associated, and only a minority of patients with advanced CKD are still referred to the nephrologist. So in this context, what is actually a diet in chronic kidney disease? Is it a system of care? Is it a prescription, or is it a concept? And what are we expecting from our patients? What is the difference between adherence and compliance? And how can we implement dietary indications, as Dr. Lerma said, in different settings and in a personalized way? Well, diet comes from Latin and Greek and means way of life. And with regard to food, it defines quantity, quality, choice, and combination of food for all animals, including us, humans. Diet is not something without, but working on a diet, since understanding, integrating, ameliorating, diet is an adaptable part of our life and is very, very culturally sensitive. Are you sure you are what you eat? Vegetarianism, health, and identity are now in some sense emerging, as Dr. Jha said, also with green nephrology. We might discuss them later in the discussion. But more and more, a diet is a global approach to patterns and is not just the classic approach dissecting the diet into proteins, carbohydrates, lipids, caloric intake, as we studied when I was in the medical school. And before going on discussing about the different options, let me just recall that we have to hear what we are expecting from our patients. Should the patients adapt to the best diet that we can prescribe, or should the diet adapt to the single patients? In a setting of concordance, therapeutic alliance, shared decision-making, is not just word. Compliance means focus on wise prescription, follow well what I suggest. Adherence is understand and adapt. Focus is on education. And concordance is let's work together to find the best feasible way to integrate in life. And the prescriptions and the final diet may be different in this context. And motivation is also important. Is it avoiding dialysis? I never tell this to my patients unless they are very old. Maybe retarding the need for kidney replacement therapy. Maybe living better, because probably better being on a diet than on dialysis, or navigating through a complex life phase, like, for instance, pregnancy. So 3 papers are important to put the diet in the context in the new millennium. This fantastic commentary by 2 giants of nephrology, and Remuzzi diets for patients with kidney disease, still worth prescribing 20 years ago. It's the first paper in which clearly it's divided but by reducing the workload on remnant nephrons, we may have an effect on progression. But by reducing metabolic waste, we may stabilize the metabolic picture and retard dialysis. What changed everything was the ideal study that showed, but actually dialysis too early, the healthy dialysis, was not healthy at all, and led first the Canadian Society and then all other societies to define another motto: intent to defer dialysis as late as possible. And here the diet comes of hand. Let's focus on protein intake in the 2 main guidelines. 2020, the KDIGO guidelines built only on randomized trials that come out with the strongest possible indication, 1A, adults, all adults, regardless of the progression of kidney disease, CKD 3 to 5, metabolically stable, should be either on a low protein diet, 0.5, 0.6, or on a very low protein supplemented diet. Very, very strong, the strongest ever. Milder indications, 0.6, 0.8 for diabetic patients. And another very important point already underlined is the first time that we come out of the old idea that half of the proteins should be of animal origin. So indication of nutritional assessment in all stages, sharp indication on protein restriction, moderate restriction in diabetic patients, flexibility on protein source. Let's not forget that we have always to start from energy. Is everybody agreeing? Not really. Even if, as we saw, the KDIGO puts the diet on the bottom of a pyramid or on the top of the things that we have to do, and even if they acknowledge more clearly the fact that plant-based proteins are probably healthier, the indication is not strong at all. It's just to see a rather weak one of a protein intake that is 0.8 gram per kilogram per day. Just avoid very high protein intake in adults at risk of progression. And in a very selected group of patients, you can go down to very low protein diets supplemented with essential amino acids and keto acids. Let me just recall you that 1.3 is not indicated for anybody, and even the World Health Organization suggests that a healthy diet is 0.8 for everybody. So ambiguous indication to normalize protein intake, just avoid 1.3 grams of proteins in stable patients. Maybe it could be discussed. This can be sound in some elderly patients. No indication for moderate protein restriction, very low protein diets in selected cases, and preference for plant-based diets. Why is so different? Why the same evidence leads to 1A and 2C? Well, let's have a rapid look of the systematic reviews of the randomized trials on which both guidelines are based. 2000, there were 1,500 patients. 6 years later, 1,500 patients. Then some years later, 2,000. Almost 3,000 in 2018, and almost 2,000, nothing more, at the time of a KDIGO guidelines. Why is it so difficult to randomize a diet? Well, it's difficult to randomize a diet. This is easily understood. But let's look at two very nice trials with very low protein diets. One from Italy, diet or dialysis in the elderly, 300 patients screened for eligibility and only 1/3 enrolled. Why? Because patients did not want to be randomized to diet or dialysis. They wanted to try the diet. And even more complicated was the recruitment in this fantastic study of Garneata, that is the one that weights more on the very low protein diets. So advantage of very low protein diet, of course, but out of 1,400 patients screened for eligibility, only 200 were enrolled. So it's really a niche for the few. So the evidence on low and very low protein diets integrated in the guidelines derives from about 3,000 patients observed over more than 60 years in randomized trials. The results are overall favorable, less proteins, less progression, and are sound from a physiopathology point of view, but only 3,000 patients may suggest that randomized trials may not be the best way to study low protein, very low protein diets, and results could be integrated by observational studies. So where can we go? What should we do in the practice? Personalized approach. I'm very happy we are on the same page, Dr. Lerma. And healthy diets. Let's not comment on the quality issue. It's intuitive that this is not a really good plant-based diet, but let me just remind you that if you look at different food that looks all the same, like carrots, the ultra-processed food costs less, lasts longer, and may be more practical. So the practical issues and the economic issues are very, very important. What is personalized nutrition? Well, personalized nutrition is a new way of looking at nutrition in a more comprehensive way: phenotype, microbiome, metabolism, exercise, dietary habits, genetics, proteomics, genomics. So how can one size of protein fit all? Difficult to say. But we have a bright example in nephrology on how recommendations may include flexibility and personalization. This is the example of a recommendations for peritoneal dialysis, in which what they convey is not a target, is a pathway, is a complex pathway. And the figure 1, that is my favorite one, is complexity of care when prescribing high quality, in this case, peritoneal dialysis. But we try to do something similar for nutrition in elderly patients. I asked for permission, Vina Brown, to start from her graph, and we wanted to underline the complexity of a high-quality dietary prescription in the elderly. Is not one prescription, is a pathway. So from theory to practice, what is the menu? We can look at the diets in quantity, and we can have moderately restricted, traditional vegan diets with protein-free food, for example, in supplemented diets, 0.6, and very low protein diets that are, of course, supplemented. But we can look at quality. We can have diets with mixed proteins or diet based on vegetable proteins with or without supplementation. And what about supplementation? Of course, it's needed when you have very low protein diets and vegan diet. But you can look at the supplementation in 2 different ways. As drugs, in this case, they are meant to reduce urea level, to exert anti-inflammatory and other effects, or as supplements to allow for very low protein diets, to simplify the life of some patients, especially in Europe, on plant-based low protein diets, or to contrast malnutrition in chronic kidney disease. This is not the same, because if keto acids are seen as drugs, they should be given in fixed quantities, while if they are considered supplements, their use may be more flexible and they can be added on in other situations as malnutrition or nephrotic syndrome. This is the old advice of the European group on supplemented low protein diet, very gradual. And this is a very nice study from the group of Denis Fouque, underlining how the pleiotropic effect of very low protein diets plus minus keto acids and amino acids is not just retarding chronic kidney disease. One size definitely does not fit all. Let me show very rapidly some examples of doing low protein diets worldwide, where the protein intake of basic is very high. Probably just reducing to 0.8 is a challenge. In some places like Sweden, changing habits is difficult. Instead of changing habits, one can play on quantity. Local diets are always easier to follow, like the experience in Brazil or Cameroon. A concordance model allows also recruiting people that is illiterate. That is not only a problem in developing countries, but it's also important to have a goal. For example, this group from Romania used very low protein diets to leave the time of fistula to mature. And we used them, and we love to use them during pregnancy in women with advanced chronic kidney disease or heavy proteinuria. Processed food and high protein food are recent. So going back to the roots may give some very interesting insights. And I'm a fan of Indian cuisine, which is huge, fantastic. We all have to learn from you. And diet should probably be seen also as a system, not just as a prescription, but as I said, as a pathway. This is what we do in France. First of all, you have to assess the patient to see what they eat, to correct the wrong nutrition. And then we normalize to 0.8, and then we start reducing. Eventually, we add keto analogs. Sometimes we add them in elderly patients on the top of not so low protein diets, but not to increase animal proteins. And then we may reduce in a smaller group of patients. This is basically the system that we developed in Italy, trying to allocate traditional diets and vegan diets, not supplemental, to people who is new age and natural. Young people use often simple diets, and we used a lot of vegan supplemented diets, 0.6 supplemented diets. And in the elderly, we had protein-free food. And we could combine all these approaches that are basically 0.6 in highly committed patients to go back to 0.3. But these highly committed patients, like in the Garneata study, are not more than 10%. And this idea is adaptable to other situations, as we adapted it to France when we went there with different habits. And patients may change, but diet is not something fixed. They can change, they can alternate. They have to live all their life with it. They have to have some freedom. And the last thing I would like to comment upon is that tailoring diets and doing a diet does not stop once you start a dialysis. This is a 10-year-old study now. When I was still in Italy, we saw that when some patients recovered a little bit of kidney function, we put them on a diet, and we were able sometimes to take them out from dialysis. There are experiences with incremental dialysis worldwide. This is a very nice study from Japan, but has been done for more than 40 years in Italy, combining low protein diets, different types of low protein diets, with infrequent dialysis. And this is a very nice abstract that was shown in recent era, stepwise incremental hemodialysis and low protein diet supplemented with keto analogs to preserve residual kidney function. There are also some interesting data on this kind on peritoneal dialysis. But let me end up with our experience on incremental dialysis. We start, and we are in Europe probably the center that starts more patients on incremental dialysis. 65% of the patients start incrementally, and they have the same results as the patients who start non-incrementally, and in the long term, they may do better. But les jeux sont faits, the games are done before dialysis. If patients are followed up intensively and with a diet, and regardless of the diet, but with nutritional prescriptions, they have 10 times more chances of being able to start dialysis incrementally, and even when they have to start dialysis, to do less. So, a good renal diet may delay dialysis need, but the renal diet is more production of proteins or addition of supplements. The availability of several options probably improves the results of each one and the quality of life of CKD patients. Personalization requires setting goals with each patient and reviewing them. And it requires empowerment, education, multiple choices, changes. If we assume that prevention costs less than care, patient-friendly attitudes are worthy, patients are better when not on dialysis, we have also to acknowledge that markets, at least in Europe, cost more than healthy food may cost more than ultra-processed food. So if food is a medicine, we need to improve the way we deliver healthy, personalized, and affordable food to our CKD patients. And I thank you very much for your attention.
Thank you very much, Dr. Piccoli, for that wonderful presentation and bringing out the topic of diet and its interaction with chronic disease, especially kidney disease, in all its complexity. And thank you also for highlighting the value of personalization, making the diet fit the patient rather than patient fitting a specific kind of prescription. Your point towards the end about supermarkets being cheaper than markets is really a good one. Even as we advocate for high, intake of plant-based diets, we have to also keep in mind as to what does it mean in terms of individuals having to stick to those, even get access to that. Is it all possible or not? So now we enter the question and answer session, and we have a number of questions in from the attendees already. And maybe I can start from the top. I'll just bunch a few questions that look similar and put them all together if you don't mind. So, Dr. Lerma, one of the first questions that comes is, what is the best way of measuring proteinuria or albuminuria? Is it ACR, PCR, 24-hour urine protein, etc.? Are there any differences for screening, for following up? Do you have any views around that? Is there any evidence?
Yeah, I think for my so what I'll share is what I do in my practice, recognizing that GFR and ACR are the main things that we use to sort of diagnose and stratify these patients. So I use ACR especially for screening. So when I see a patient, I measure the ACR and then I would plot them in the heat map and show them where the heat map is. And that sort of gives a patient an idea as to where I am in the realm of progression. That's one. Now, there's also the school of thought that, and you probably can comment about this, Dr. Jha, in glomerular diseases, probably it is more useful to collect your 24-hour urine protein sometimes, especially if you're trying to, determine if you need to alter your treatment or not. I know this is something that is probably not necessarily agreed upon by everybody. But I know some glomerular disease experts would prefer to follow a 24-hour urine protein, although we recognize that it is more cumbersome to do a 24-hour urine protein. It is less practical. And sometimes, there is inaccuracy in it, but there is also some inaccuracy and limitations in interpreting your ACR and PCR.
Yeah, thank you. Dr. Piccoli, I think it would be useful to hear from you as well as to what is your practice with regard to proteinuria measurements and follow-ups.
Well, it changed from Italy to France. In Italy, we had a rather younger population with more glomerular diseases, and also in CKD patients, since we were always pretty much interested in protein, but also in salt intake and in phosphate intake, we used to ask for 24-hour urine collection. And this is fantastic because, the body is a box. You get in, you get out. So it, of course, it's not just urine, but it was very, very useful in regulating the diet. Yeah. And some aspects of the diet, like sodium intake, but we used not to a priori, but we reduced when we had a high urinary sodium, for example. In France, we follow a much older population, more like the Japan one. 15% of our patients are over 90 years old, and we follow them for CKD stage 4 and 5. So it's very unpractical in these cases to use 24-hour urine collection. So we try to do them as much as possible because we work a lot on diets, and there is nothing. It's not just proteinuria. Is urea, protein intake, is sodium. But we do with, as French people say, les moyens du bord, what we have on the sheet to navigate.
Yes, thank you. So that brings out the point that I think we have to be flexible. There is no single correct approach. And we also should understand as to what is the purpose for which we are doing this testing. If, as Dr. Lerma said, if you're looking at where to put this person in the heat map, then obviously we should do ACR because that is the basis on which the heat map was developed. If you're thinking of glomerular disease as a possibility, and or also if we want to do comprehensive evaluation, then definitely 24-hour urine protein is the best way to go. And of course, we need to be practical. Whatever is possible, whatever is available on the shelf is what you go with at that time. So that's good advice. But very quickly, Dr. Lerma, can glycosuria with SGLT2 inhibitors affect ACR results?
Yeah, so this is something that I guess we all look into, you know. So whenever I see a patient whom I'm going to start an SGLT2 inhibitor, I usually check them first. ACR, PCR, see if is there an indication to start this patient on an SGLT2 inhibitor. So I would at least have that. I'd be able to place them on the heat map. I later on, you know, obviously there's there's the dictum that certainly glucose may be able to affect some of this situation. So I think you kind of have to interpret it with a grain of salt, you know, no pun intended, obviously. But certainly glucosuria is expected with an SGLT2 inhibitor, and you know, at least you have your baseline to compare. How did your ACR, what was the trajectory of your ACR from the time that before you started and after you started, and where do you go from there? Let's say, a hypothetical example, patient comes in, 2 grams proteinuria, DKD, and then I put them on RAS, and then I put them on an SGLT2, and they're still significant albuminuria. That's when I then consider, should I add an MRA in this patient because they're still not optimized. You know, again, now highlighting the 4-pillar approach.
Great, thank you. But there is no evidence to suggest that at least it interferes with the assay, right?
That's right.
Okay. So one question here is that do sick day rules apply also to perioperative period, especially with regard to elective surgery?
The answer is yes. You know, obviously, if the patient is placed on NPO for 24 hours, you know, and then you know that the patient is going to undergo some major surgery, it may be prudent to do that. But again, this is done on a case by case basis. Everything has to be individualized, in my opinion.
All right, very good. And the next question is that if you stop RAS blockers because the GFR has fallen by more than 30%, do you restart? If yes, what is the threshold?
So when you see that greater than 30% increase increase in creatinine, that makes you want to stop or hold up the RAS inhibitor. The reason you're doing that is because you are going to reevaluate. Does the patient actually have a renal artery stenosis or renovascular disease that is causing that situation? B, is there any intercurrent illness? Is the patient on any other medication that in combination with that RAS inhibitor is causing the problem? So once you reevaluate all of this stuff and then you are able to eliminate them, then I would say, okay, then if there's no contraindication, restart it and see how the patient does.
Great, thank you. There's an interesting question. Are the recommendations regarding restricting protein intake or whatever threshold has been advised the same in proteinuric and non-proteinuric chronic kidney disease, or do you need to also factor in the amount of proteinuria when advising patients regarding protein intake? So maybe Dr. Piccoli, if you can take that one first.
Well, it's a very good question. It depends upon the level of proteinuria, of course. But there used to be, the old idea was that you reduced protein intake and then you added some proteins to compensate for losses. It's a very naive idea because what we see in the urine is just the tip of the iceberg. We may have a patient with diabetic kidney disease that loses that has 5 grams proteinuria per day and has normal serum albumin because everything is failing but tubule 2. But if you find a boy with minimal change disease with 5 grams of proteinuria, he will have one of albumin. So it's not proteinuria. We don't see what happens in the kidney. I would say it's more the albumin levels that counts, like in pregnancy. So giving more proteins increases glomerular filtration that may become very critical on the top of nephrotic syndrome that is already a hyperfiltration stress. So today, the point is always to what we say is do not add proteins, but if you have to treat a patient with severe resistant nephrotic syndrome, you may make a trial, and there are some evidence on relatively small studies, because of course, these are the patients that do not respond to other treatments, but even show that very low protein diets may reduce proteinuria and induce remission. Why? No one knows. Probably for a mix of hemodynamic factors, but also maybe because they remove some antigens that we are not aware of. On the other hand, it's having a patient with nephrotic syndrome under treatment with immunodepressive therapy. Well, I would care more, especially if there are steroids, then use a wise approach to low protein diets after remission. May I add one last thing, that even if I don't want to be the advertiser of anything, including keto acids, but they are the only protein supplements that do not really increase. They look more like plant proteins, so they do not increase they do not induce further hyperfiltration, and they can be used on the top of a well-balanced diet in nephrotic syndrome. So it's a case by case, but the rules, one size fits all, you add proteins, no more. Look at albumin and decide according to the treatment options what to do.
Your thoughts on that topic, Dr. Lerma?
I think we have to be, again, careful about putting much stock on the degree of proteinuria. Again, we know proteinuria is a marker of disease, and we know that it sort of guides us into what are the next steps into treating the patient and slowing CKD progression, right? Using your RAS inhibitors, your SGLT2 inhibitors, so on and so forth. So, we have to be careful also, remember when we, I think Dr. Piccoli brought this up earlier, if a patient is already, have a low albumin already, and that these are usually the patients that you see have a lot of degree of more proteinuria or severity of proteinuria. So, I always believe individualization is key in these patients.
Yeah, thank you. So, Dr. Piccoli, you repeatedly mentioned the term a committed patient. I think that is something that we aspire to. I mean, we all want a patient who is committed to taking care of their own illness, because that's not easy, especially in this context of very low protein diet. Committing to that kind of regime is not straightforward. And there are a number of questions here with regard to very low protein diet and normally low protein intake in certain populations, such as that in India, because a large proportion of Indian population is already vegetarian. So what exactly do we do in that situation? In that, do you think that use of these agents like keto analogs, etc., would help at all in this situation?
Well, this is it's a very interesting question that maybe is something that could be seen rarely because in Europe we are more carnivorous. But sometimes in some specific patients or in patients, for example, with anorexia, the protein intake is already very low. There is advanced chronic kidney disease. So if we see keto analogs, like if we look at them like supplements and not like drugs, and if we see a patient that is at risk of malnutrition, they are the best thing to add in this context. You don't increase proteins, you just give something that is a precursor that does not affect hyperfiltration. It's logical, it's sound, and this is what we do in some cases in some patients that are malnourished, but have they have mainly a low protein intake, anorexia, or are very old. We use this on the top, but this is not the way they are sold, at least in Europe. So if we use them as supplements, it's absolutely okay. If we want to see some miracle, well, I would doubt a little bit. But it's clearly better than other choices that we can have, like giving those horrible hyper-processed beverages with 400 calories and 20 grams of proteins. So it depends. It's a case by case. I personally do not think, and the results that have been done in animal studies suggest that the effect of using up urea is minor. Is probably less than 10% of all urea, so it's just. But they may feel a gap for patients that you want to give something that is not meat.
Yeah, thank you. Another interesting question, and this is something which might perhaps you might be able to throw a light on based on your experience. Do you notice protein restriction leading to malnutrition in patients with chronic kidney disease? If so, what are your thoughts about how should these people be monitored and how should the dietary evaluation be done? Do your patients get regular dietary counseling through nutritionists, etc.?
Well, we are lucky. We are rich. We are lucky. We have set up, for example, in my hospital, we have 4 dietitians that work with us in dialysis, pre-dialysis, and hospitalization. So we have the possibility of making frequent controls. In the area where I work, malnutrition is very rare. The problem is obesity. Half of the median BMI of a population in the unit for advanced kidney disease, median GFR 25, median BMI 29. So we do not see that many cases. But in Italy, for example, it's different because it's a leaner population. And it's more frequent to have borderline malnutrition. But either the nephrologists or the dietitian have to be skilled, especially if it's the case of very low protein. Also because for some patients, this becomes a sort of magic. So they don't eat enough. They are scared. They get scared to eat. This is also, we always leave at least 1 up to 3 unrestricted meals per week. 1 day per week, forget about the diet. This is the best way to avoid malnutrition. So the point is that we hope to do our job pretty well. And if we have a patient that is a subjective global assessment C, severely malnourished, obviously, we not put him or her on a diet. The problem may be the problem with the newcomers. And if I can make a slight commentary on the KDIGO, you cannot say on one hand, just be careful not to do too much, 1.3 grams, then go to 1.8, but drop to 0.4, because the game is done in the middle, and going to 0.3 is a stepwise phase. And if you have a patient that with an 0.6 diet goes like a charm, why going lower? So it's a more complicated pathway. And if you, the only mistakes that I remember having seen were from some groups that were very obsessed by the 0.3 diet and no more than that. With flexibility and adapting to the patients, I've never had a malnourished patient because of our diets, but we have many patients that are on 0.7, 0.8, 0.6, and very few patients that are on 0.3. I don't know if I answered.
Yeah. What proportion of your patients would be on 0.3 grams?
In Italy and France, we are about 10%.
10%. That's helpful. I know that we are almost at the end of our time. Just one very last question, Dr. Lerma. There's a question that with regard to ACE inhibitors, ARBs, and SGLT2 inhibitors, can they be started together or should they be sequenced in some way?
So there's actually a nice editorial written by Brendan Nguyen, Catherine Tuttle, and the late Dr. George Bacris. And I actually just retweeted this. It's regarding the timing and optimization of this targeted therapy for patients with CKD. So in the traditional approach is that you place a patient on a RAS inhibition 3 months. During that time, you're titrating the medication. And then in the next 6 months, you work on your SGLT2. You titrate the dose. In the next 6 months, then you add your MRA. That's the traditional approach. Then there's the accelerated approach, wherein you give your RAS inhibition for 3 months, and the next 3 months, instead of 6 months, you use your SGLT2 inhibitor, so on and so forth. And then there's the controversial rapid approach, wherein you start the patient on an MRA, SGLT2, and RAS inhibitor at the same time. And the caveat here is that this is for patients who are at very high risk for progression. Certainly, this is thought-provoking because you start a combination of medications with different mechanisms. You are also toying about different side effects. And I think we have to be careful with that. Certainly the idea is there. I agree with it. At the end of the day, these are still 4 pills that you're trying to or 3 pills that you're trying to combine and have the patient take. So there's right now, there's research. I know Brendan Nguyen, I think, is working with somebody on this and coming up with a poly pill in these patients. So I know, Dr. Jha, I may have answered your question rather in a circuitous way, but I hope the person who asked the question gets the point.
Thank you. Circuitous nonetheless, but an answer. So that's good. So thank you. All that remains for me to do is to thank both of you, Dr. Lerma and Dr. Piccoli, for the wonderful presentations and being kind enough to take on all the questions and answers that came our way. There are a number of other questions also, which I have tried to combine while putting them to you. And I hope that the people who asked those questions have gotten the answers they were looking for. But as was said in the beginning, recording will be made available through appropriate channels, likely the KDIGO website or other channels. And I with those words, I hand it back to you, Dr. Shah, or Mr. Sahai.
Thank you, sir. Thank you very much. So, as we come close to the insightful and enriching webinar, I would like to extend our deepest gratitude, sir, to our distinguished speaker, Dr. Edgar Lerma and Dr. Piccoli. Dr. Lerma, your expertise and comprehensive session on KDIGO 2024 guideline have provided us with valuable knowledge and practical insight that will undoubtedly enhance our understanding and approach to CKD. And Dr. Piccoli, your profound discussion on the diet and the other treatment modalities in CKD has gave us the critical aspect of CKD management. We are immensely grateful to your time and efforts both of you have invested in preparing and delivering such impactful presentation. Your contribution has not only educated us but also inspired us to continue our effort in combating CKD with renowned vigor and commitment. Thank you once again, Dr. Lerma and Dr. Piccoli, for your invaluable participation. Dr. Jha, your moderation has been instrumental in guiding us in our discussion and ensuring that we had a productive and engaging session. Thank you, Dr. Jha, for your outstanding moderation and for helping us navigate through the important topic with such expertise. I sincerely thank all the delegates for taking your valuable time out for this session. And I hope that with this new insights, we can improve the patient outcome in effective manner in management of CKD. Once again, thanks all of you and have a good night.